Halyna Strelko is back with us. Hello, Dr. Halyna. How are you feeling? It's great to have you back as always.
Hello, I'm really happy to see you, to hear you, and to do this webinar because this is the really interesting topic and very modern approach. So we will try to see why it may be helpful and to whom it may be helpful.
Brilliant. That's why we are here, of course. So remember, we will start with Dr. Halyna's presentation, but afterwards there will be time for your questions. If you have them prepared, you can put those in the chat section even now. If not, then of course, remember, you can do it later on as well. And I'm sure Dr. Halyna will be happy to help you out. Let me just remind everyone that Dr. Halyna is the co-founder, leading reproduction specialist at IVMED, located in Kiev, Ukraine. So thank you so much for joining us tonight. I'm sure it's going to be an interesting session again. So before we start, let me just add that European Fertility Society is proudly supported by PhenoMatch, the tool that will help you find a suitable donor. If you haven't seen it, I can only encourage you to have a look at this on their website to find out more. Many clinics are using this tool already. You can check this out. And also, I would like to encourage anyone, if you would like to help us out, you can volunteer. We are still looking for transcriptionists who will help us with some of the description of the presentation of our past webinars, but also Q&A sessions. So if you feel that this is something you could help us with, please get in touch with me. I am Caroline, or just go to our website, myivfnss.com. You will find more details there. And it's the same with donation. If you are apt for it, then of course I can only encourage you to go and visit our website and support European Fertility Society, because as you know, we are all here to support patients just like you, and we want to do whatever we can to simply help you out in any way we can, of course. This is just my short introduction, but now I would love to start our session. Dr. Halyna, are you ready with your presentation?
Yeah, sure. Could you switch
Yes,
on?
of course, it's right here. Thank you so much. Let's get started.
Thank you for your kind presentation. And so we will move to our topic, how and when double or multiple stimulation may help patients in IVF outcome. And we will see today some theoretical issues which can explain why it may be helpful and why it is not so wide used. So let's see what we can discuss today. We will see the rationale of double stimulation, to whom it may be interesting. We will see about fertility preservation, because this is the topic where first time was used such approach. Also, we will see a couple of slides about egg donation and poor responders. And also why we should thinking about specific gonadotropins during luteal phase stimulations or double stimulations. So current stimulation protocols, standard protocols, classic protocols based on the human follicular dynamic known as Proprius moment theory. It means that follicles constantly growing, and one moment when FSH increase, they start to grow in more quickly, and what we're using during the controlled ovarian stimulation. But the new paradigm of human follicular dynamic, which we call follicular waves, was revealed using sequential ultrasound examination. And this paradigm showed that there are different follicular waves. It means that follicles growing not constantly, but by groups. And normally we can discover 2 or 3 waves of follicles growing. More often in young women it is 2 waves, and in late reproductive age we can see more often 3 waves. Why it is important? Because during this wave, we can constate that we can see more antral follicles sensitive to stimulation. And sometime in luteal phase, not in the beginning of the cycle, but in the second phase of cycle, which occur after the ovulation, we can see more antral follicles than in the first phase of cycle. Why only now we have elevated interest to this topic, to the luteal phase stimulation and to double stimulation protocols? It is mostly because dramatic improvement of protocols of cryopreservation of eggs and oocytes, because the idea of follicular waves and luteal phase stimulations first was appear in the literature at the beginning of 2000, but good cryopreservation program installed mostly 10 years later. And now, when we are 100% safe and sure that embryos will thaw in well, will survive well the cryopreservation. So now we don't need mandatory to have a fresh cycle, to fresh transfer. Yeah, we can do what we call cryotransfer. It means harvest eggs and create embryos in one cycle and then transfer in another cycle, and pregnancy rate will be even better in this case. So from this moment, different stimulation regimen was studied more attentively, because there is no risk that we cannot do the transfer later. So this increased the interest to this regimen of stimulation. After that, increased number of poor responder, late reproductive age patient, because every year we constate that we have the average age of patients which increase. Last years we has average age 38, 39 years old. It means that most of these patients has a low number of follicles, and important to receive as much as possible. Also, a lot of international treatment program. People come for 2-3 weeks, and necessary to do maximum to receive much eggs as possible for this short period. Also, egg banking, egg donation, and dramatic improvement of oncological patient treatment efficacy. It means that most of them survive, and they are more informed about the possibility of fertility preservation, but also in most of case this category of patient need quick action to receive more eggs as quick as possible. So all that increased the interest to different stimulation regimen, and especially second phase stimulation and double stimulation. So new strategies of ovarian stimulation based on concept of ovarian follicular waves permit us to change the standard stimulation approach and increase the possibility of stimulation protocols. It means that move from conventional stimulation to luteal phase stimulation or to double stimulation. So, what does it mean, double stimulation? In this picture, you can see that normally we call double stimulation the protocol when we start the stimulation from the beginning of menstrual cycle in follicular phase, then doing egg retrieval at the end, and in 1-2 days or in 3 days, start the second stimulation and do the second egg retrieval. It means that during 1 month, we can do 2 egg retrieval procedure and receive twice more eggs than in 1 egg retrieval. There are a lot of publications studying the quality of eggs and reproductive potential of these eggs and embryos from first and second phase of stimulation, because of course doctors and scientists are worried that eggs received in not physiological condition, it means under the high progesterone level influence, may has less reproductive potential than eggs retrieved in, how to say, normal conditions. Yeah, so there are a lot of publications comparing first and second phase embryological parameters and clinical parameters. For example, one of the last works show that number of metaphase 2, it means mature eggs, percentage of fertilization of these eggs, percentage of blastocyst formation, and percentage of genetically normal embryos, mostly the same when we compare the egg retrieval proceed in first and second phase of cycle of the same patient. Of course, there are some concern regarding second phase stimulation in this protocol. And the main concern, this is theoretical negative influence of high progesterone level on follicles and eggs development. Also, some concern about abnormal egg maturation during the second triggering, and also risk of spontaneous luteinization. Of course, one of the concern, it is impossibility to do the fresh embryo transfer in such protocols, but we have say that we can resolve this problem by good freezing program. So, what about egg and embryo quality? There are 2 studies published in 2016 and 17 suggest for the first time that increased serum progesterone level may be associated with a poor embryo quality. However, there are another publications which are, how to say, just opposite and not show some difference and have shown the similar implantation rate from the embryos received from first and second phase of cycle. But also recent days appear very interesting scientific work about gene expression in cumulus cells in case on luteal phase stimulation and follicular phase stimulation. Cumulus cells, we call cells surrounding oocyte, and these cells are very important to egg maturation, egg development, egg quality, and egg reproductive potential. Scientists comparing different gene expression, mostly gene expression involving in oxidative stress, in inflammation, in apoptosis, and found that there is a difference in this gene expression. Okay, this is the description of all of these genes. Doesn't matter all this name, it is impossible to remember, of course, but main idea that they found a difference in gene expression involving in inflammation, oxidative phosphorylation, apoptosis, and metabolism between luteal and follicular phase. However, results are not conclusive. They found a difference, but they cannot say exactly is it bad or good and what is the practical influence of this difference in the reproductive potential of these eggs. Now, all scientists, I agree that probably this influence is not very pronounced and need more scientific data for understanding the clinical significance of this difference. When we study different protocols, for example, for patients who need fertility preservation, this is a very good model because they come any day of cycle and there is no time to waiting. So in these patients, in this category of patients, any kind of protocols proposed, main idea to start as quickly as possible and to receive as much egg as possible. And when we compare different starts of stimulation, conventional start, random start, late follicular phase, luteal phase, double stimulation, so we can constate that finally the quality and quantity of eggs, number of mature eggs, fertilization rates, mostly the same in this category of patients. When we compare the situation with egg donors, because it is the second category of patient where double stimulation may be interesting because sometimes we need much more eggs and quickly. So this is our own investigation, results of the same egg donor stimulation in luteal and follicular phase. So double stimulation for the same donor. And we can see that we receive mostly the same number of follicles, mostly the same number of oocytes, mature oocytes percentage also mostly the same, and quantity of usable oocytes even better in luteal phase stimulation. So from a clinical point of view, from the parameter which we are able to study, we don't found big difference from the standard conventional stimulation. So, ovarian stimulation can be started regardless of, say, cycle phase and day. And this concept is based on the multiple waves of follicular recruitment. Total number of received oocyte, number of mature oocyte, and fertilization rate seem to be more or less comparable of two types of ovarian stimulation protocol. When we can see the meta-analysis of luteal phase stimulation, because when we are talking about double stimulation, it means that we are doing standard stimulation plus luteal phase stimulation. And all concern of this protocol mostly related to this second part, luteal phase stimulation. So we can constate that total dose of gonadotropin, it means total dose of FSH, of medication, and total duration of stimulation is higher. Most of authors show that it is higher. So the question is why it is like that. And as for me, the main explanation of such phenomena because in second phase of cycle, progesterone, which was produced by ovary after ovulation, after first egg retrieval, will depress own LH level. And we know very well that LH, luteinization hormone, not only FSH, but LH, need for normal follicular development, and especially in second phase of cycle. We know that expression of LH receptors observed in granulosa cells of 80% of follicles, and especially when follicle growing, number of FSH receptors decrease, and number of LH receptors increase dramatically. And there is some threshold of LH. If we have very low LH level, it increase follicular atresia, it decrease the normal follicular development, it may suppress the granulosa cell proliferation and give oocytes not good quality. Yeah. So in our clinic, we try to do some study adding luteinization hormone in stimulations protocol when we start the stimulation in second phase of cycle. There is a medication with LH inside named Pergoveris. And we has done kind of study comparing different embryological parameter when we use this medication instead of classical FSH in luteal phase of cycle. And we have found that when we use only FSH, comparing with FSH plus LH, we can see little bit more mature oocytes, much better fertilization rate. We can see also much higher, 10% higher number of day 5 blastocysts, and we have less blastocysts arriving 6th day. It means that blastocysts developing more quickly. Okay, the difference is not so pronounced, but anyway, it may improve the situation, especially in case on late reproductive age and poor ovarian reserve, because this is mostly the case where we use such difficult protocols like double stimulation protocols. Because if all is fine and we receive 30 eggs during the one stimulation, no need to do such approach. So, strategy to improve control of ovarian stimulation rate response in poor responders consist on better synchronization of follicles when we use luteal phase protocol, increase the general follicle and oocyte number when we use double stimulation protocol. It means follicular and luteal phase protocol. And when we use LH plus FSH, especially in second phase stimulation, it may also improve number and quality of eggs. So let's move to another study, big meta-analysis about the double stimulation and double oocyte retrieval in the same cycle for patients diagnosed with poor response. Now we say about poor response because, as I say, that in this category of patients, mostly we are searching some approach which can improve the number, quality of eggs, and improve the pregnancy rate. So this is very big study, very interesting study, and we can see the result. The main idea was to compare the egg quality, egg number, and what result was received. There was significant advantage of dose team in total egg number, and it is understandable because we're comparing, how to say, one stimulation with two stimulation. Of course, after two stimulation, number will be higher. What about dose team in live birth rate influence? We can see that in some study it is better, in some study it is less important, but generally it is mostly the same. As minimum, it is not worse. So, author's conclusion about dual steam protocol that it may improve clinical outcome, especially because on increasement of total number of oocytes, total number of mature oocytes, and total number of available embryos. Actual data not indicate that luteal phase stimulation decrease the quality of eggs. They don't found increase aneuploidy rate of eggs received in second phase of cycle, but still we has not enough scientific data to say the final decision. If we can have a short resume of dual steam, it is more or less understandable that we receive more eggs and more embryos. More patients obtain complete blastocyst and especially chromosomically normal blastocyst per ovarian cycle or per treatment, because we know that not all embryos has normal genetic, and average it is 50%, 60%, but depends on age. So more eggs, more genetically normal embryos. No difference in competence between oocytes obtained after follicular and luteal phase. As minimum now we have no such data. Embryological parameters mostly the same. Okay, the weak position of dual steam consists on that need more stimulation, maybe more cancellation, also more egg retrieval procedure in one cycle, which may be more traumatic. Freeze-all approach is mandatory, impossible to do fresh cycle, fresh transfer. Mostly the benefit related to poor prognosis patients, but for this category of patients, unfortunately, whatever we are doing, prognosis is always not very high. About opportunity, the dual steam may reduce the time to obtain as minimum one good quality embryo. It may be better tolerated by patient because, okay, it is more quickly. It is a reduced dropout rate because more than 60% stop their treatment because feel it so long, so heavy. Okay, we need more knowledge about physiology of this process. About cost effectiveness of dual steam, okay, also it is discussed, maybe discussed. Increased total dose of gonadotropin, especially in second phase of cycle, may be reduced by changing the gonadotropin used in second phase. And obstetrical, gynecological, biological, neonatal outcome is not totally known now. So need more data. So as K take home message, I can state that dual steam is very interesting and promising approach in some category of patients. I think that mostly three categories of patients can be the most beneficial for dual steam. Egg donation patients, poor responders, and fertility preservation patients. For international patients, for some traveling patients, also it may be very helpful in some conditions. Adding LH in second phase stimulation may be more important and may improve the response and quality of eggs of second phase stimulation. It may be some influence on egg maturation and reproductive potential of these eggs, especially received after second phase stimulation, but we need much more data. So, uh, duo stim, my answer is yes, but right patient and right circumstance. So, thank you very much for your kind attention. Now I'm ready to answer your question.
Brilliant as always. Thank you so much for explaining. You've been very thorough as always. So thanks a lot for that. I do believe that it's now more clear to everyone. So right now, this is your favorite part. If you have questions, put those in the chat section. Dr. Halyna, I'm sure will be happy to help you out. And so this is your time, okay? So don't hesitate. Anything that's on your mind, put this in the chat section. And we have the first question from Fran right here. So let's have a look. My son and wife have had 4 or 5 rounds of ICSI, 1 pregnancy, second round with new micro TZ harvested sperm, but failure since. Always 10, 12 eggs, but there were no embryos from the last round. She's 35 and healthy. They have enough frozen sperm for one last round. Should they consider double multi-stimulation for this last attempt?
Good question. Thank you very much. The main question from my side, how old is she's 35. Okay, so she's young. Look, double stimulation, okay, may help to receive more eggs. Maybe in some time when we start the stimulation not in follicular phase but in luteal phase, we can see more antral follicles and receive not 10 eggs but 15 or 20. Sometime it may be helpful, but in this case, probably there is some problem in sperm cells. It is difficult to say because if there is no blastocyst formation, if embryo does not developing, it is one situation. If your embryological laboratory receive nice blastocyst and they don't implant, it is another situation. If, for example, they don't do genetic test on the embryos, probably this is the moment to control if there is a good genetic of these embryos, because if embryos has abnormal genetic, they will not implant. So necessary to know a little bit more to be able to explain the situation.
All right, Fran, if there's anything you can add, just go ahead, okay? And I'm sure Dr. Halyna will be happy to give you some more details, but thanks a lot for your first question here. Okay, I'm maybe Fran is already typing, but so let's go to the next question and we will go back if
Okay, and we will have to return.
Exactly. How about this? Are there risks and side effects of double stimulation?
Yes and no. Probably there is a risk because ovary after the first stimulation are enlarged, the blood circulation is increased, and probably there is a little bit more risk during the second egg collection. Okay, now we have not enough data to say the numbers, but this is maybe one risk. Other risks, also we don't know, but probably there is a influence in egg number, egg quality, and some embryological parameters, because we have seen that there are different gene expression in luteal phase, but now we have not enough data to show some clinical difference. Probably need more time, more data, more information. So, if necessary to do double stimulation because on fertility preservation, because of no time, because on, I don't know, international patient, okay, I prefer to do that. But if a woman is able to come and to do two normal stimulation and know this circumstance when we should hurry up, I prefer to do two classic to normal stimulation.
Thank you so much for explaining. And we will go back to a follow up from Fran from our previous patient. Okay. So she added that they had some embryos from previous rounds, but all failed. Just the last one was surprisingly poor with no embryos. My son's frozen sperm has excellent DNA fragmentation.
Mhm. Um, Look, in most of case, the embryo quality depends 90% on egg quality and approximately 10-15% of sperm quality. So, even with very, very bad sperm, but very good egg, the result are mostly good and just opposite. If we have some problem inside of oocyte, even with very good sperm, we will not receive good embryo. So probably if there is no embryos, it may be the problem of fertilization, it may be the problem of egg maturity, it may be the problem of laboratory also, because sometimes some laboratory condition may decrease the probability to good embryo formation. So necessary to talk with laboratory, with the doctor, and see the situation. In some case, we can do kind of, I don't know, proof, but of course not in your case. But when I have patient 42, 43 years old, I propose to do with donors eggs as well. And sometimes we can see that with own eggs result is not good, but with donors eggs result is much better. It means that it is not the sperm condition, but rather egg condition. But in your case, probably it is not a good idea. But I would like to say that this is only one way to understand the problem is inside of sperm or inside of egg. So probably in your case, necessary try to choose different stimulation protocol, probably to see something new in triggering final egg maturation, because sometimes eggs are not mature enough, and probably try to speak about some changes in fertilization and embryological approach. For example, maybe used calcium ionophore, which increase the fertilization rate, for example. So different possibility. Necessary to speak with laboratory and with doctor and see the exact situation with eggs and embryos. After that will be more easy to say something.
Of course, that makes sense. Thank you so much. I believe that was helpful. Sorry. Calcium, you
Okay.
mentioned, I think. Fran is asking, let us know, Fran. The last
Last
idea. It's about
uh,
calcium. You mentioned that.
calcium ionophore. There is some kind of medium which increase the concentration of calcium inside of oocyte, and it is improve fertilization and development rate. So for some cases like that, when we have low fertilization rate or bad oocyte quality or late reproductive age, we use such medium, and sometimes it improve outcome. So necessary to speak with embryological laboratory and see their possibility and their idea, because first time there was embryos and second time there was no, so they should has kind of explanation.
Mm-hmm. This
Yeah,
case.
increase the calcium concentration in oocyte. Fertilization in physiological condition is like that. Fertilization provoke calcium ions increasement inside of oocyte. So using such medium sometime improve the fertilization rate. Calcium ionophore, the name of this medium.
Yep.
So you can try to talk with.
Exactly. Yes, I remember that you mentioned about this in your previous webinars as well, right? So, Fran,
Yeah,
I
yeah,
can
yeah,
also advise you to have a look at the previous webinars. I'm sure you'll find it there. You will be redirected to a profile of Dr. Strelko with all the previous webinars she has done. So feel free to have a look at this, and I'm sure it's going to be helpful too. And of course, there's a thank you for very much for insights from Fran. Thank you indeed. All right.
Mm.
Let's go to our next patient. Rachel has a question for you as well. I've suffered 3 natural miscarriages, weeks 10, 12, and in 2 of them, the embryos were found to be chromosomically,
So abnormally,
abnormal. Also undergone 3 IVF cycles where number of eggs collected was on average of 8 per cycle. Only 3 embryos reached blastocyst stage, all of them found to be abnormal after PGTA testing. All the treatments were done last year. I'm 40 now and have high AMH. Our karyotypes are normal and no issues found in any tests. Would double stimulation be recommended for our
Mhm.
case?
Good question. Thank you for this question. So, abnormality of embryo depends on egg quality, depend the how to say, if we take 100% abnormality, the source of this abnormality mostly four sources. So one, egg. Second part of this abnormality occur during fertilization. Third part depends on sperm. It is not a lot, it is around maybe 10-15%. Previous two sources, it is around 30% each. And around 30% during the embryo development. So during the stimulation and fertilization, probably we cannot influence a lot on this process, but probably optimizing embryological conditions, we can improve a little bit this last part, I mean during embryo development. Because there was some publication that in some laboratory with donor eggs, there was 40% of genetically abnormal embryos, but in some laboratory, 80%. It means that laboratory condition may influence the percentage, but also it may be quality of egg. Yeah, so it is difficult to say in each case which happened. Yeah, but double stimulation can permit you to receive more eggs, not 8 but 16. Of course, the probability to have in this case as minimum 1 or 2 genetically normal embryo will be higher than with 8 eggs. Also, probably if you have high IMH level, probably necessary to talk with your doctor to start with higher dosage, probably 8 LH, which can improve the egg quality, and to see if you receive 16 or 20 good quality eggs, probably you will have more chance to finally receive chromosomically normal blastocyst.
All right. Thank you so much indeed, Rachel, for your question. And of course, thank you for your advice here. Okay. Rachel, if there's anything else, of course, go ahead, type this in. But I think it was quite a thorough answer already. So I hope that helped. Elle has a short question. What is the most aggressive IVF protocol?
Look, what do you mean aggressive? Finally, the goal of IVF protocol to receive more eggs and more quickly, yeah, and best quality. So, in case on, for example, PCOS, polycystic ovarian syndrome, situation when a woman has a lot of little follicles. Okay, and we will do even standard stimulation with standard dose. We will receive approximately, I don't know, 50 or 60 or 70 follicles. It will be quite aggressive because dosage of estrogens will be huge and the risk of bleeding during the egg retrieval will be high, and the risk of ovarian hyperstimulation syndrome will be also high. And this we can call as aggressive IVF protocol. But it is rather depend on basic patient condition and not on, how to say, stimulation strategy. If you mean, for example, poor responder or patient with resistant ovary, that mean that you have normal IMH level, apparently there are follicles, but they don't growing. And in this case, we can do quite aggressive stimulation with high dosage, like 400 units, 450 units. For example, adding LH, adding anti-estrogens at the same time. Even there are some works concealing to add growth hormone. And in this case, we will receive better answer to stimulation. So I necessary to specify what do you mean aggressive IVF protocol.
Thank you so much indeed. If there's anything else you would like to know, you know what to do. Thanks a lot. And actually, let's go back to the previous patient, Rachel. Okay, she would like to know. So the recommendation would be adding LH to the IVF protocol to improve quality of the eggs. Then is that done through injections?
Yeah, it may be helpful. Especially for women after 36 years old, using the recombinant LH during the stimulation was shown as beneficial to improve egg number and quality. Of course, it will not improve 5 times. Yeah, it will improve 5%, 10%, but it may be helpful. LH exists in medication named Pergoveris, so it is FSH plus LH. So if in your country it is in registered, I think possible to use it.
Okay. Thank you. Thank you so much for your follow up as well, Rachel. Karen has another question for you here. A few of them, three of them. All right. So, first one is I'm interested to know how back to back cycles improve embryo quality. Is back to back considered two separate months or in the same cycle with follicular and luteal phase stimulation? Which approach is typically better?
Okay, if you mean back-to-back cycle, it means two consecutive stimulation. Yeah, increased FSH and estradiol level may decrease what we call apoptose of follicles, and we can see that in first cycle, at the beginning we have like I don't know 5 follicles, but in second cycle, this anti-apoptotic effect of stimulation may show us that we have 7 follicles and the next cycle 8 follicles. So sometime we can see this situation, and consecutive stimulation may be helpful to receive more eggs. But also it may be due not specifically to the stimulation, but to different wave of follicle growing, because we have seen at the beginning of the presentation that there are several waves of follicle growing during the cycle, and some waves may be better than another one. It means that if we not stimulating but waiting when we will see more follicles, probably in 1 and 2 months we will discover such cycle, and in this cycle we will receive more follicles and more eggs just because this is the better wave of follicle growing.
All right, thank you so much. And let's have a look. Karen has added one more question. I have seen a number of ladies say they had normal tested embryos after doing back to back cycles. Is there any theory around this?
Stimulation, back-to-back stimulation, consecutive cycle stimulation does not decrease the embryo quality. As minimum, published works does not show decrease of number of mature oocyte, number of good quality embryos, number of abnormal embryos if we stimulate 2-3 times consecutively or second phase stimulation. So it's true that there is no published results showing worse situation with consecutive stimulation. About normal embryo seems in second stimulation. Okay, it depends. I have done several double stimulation, and it's true that in some case we have better results, but in some case not. Normally, if patient asking me about that, we discuss that if after egg retrieval I can found little antral follicles and there is enough, we start second stimulation. But sometimes I don't see even one, and in this case better to stop. So there is no, how to say, standard rule in this case, necessary to see case by case. In some case I agree with you that may be better.
Okay, thank you for your interesting questions indeed, Karen. And there's a thank you from her. There's one more question actually. Sorry. For age 40 age group, is it generally better to stimulate with FSH or a medication with FSH such as Gonadotropin or FSH and LH combined, such as menopur?
Look, normally better to stimulate FSH plus LH, but it is not menopur. Menopur, it is FSH plus HCG. It is right and that there is LH activity, but it is not LH. It is chorionic gonadotropin. Because when menopur is medication produced from urine, it is urinary gonadotropin, and it is high purified gonadotropin. And when they are purifying this FSH from urine, LHs disappear from this preparation. And after, to add some LH activity, add HCG, chorionic gonadotropin. So LH activity is in menopur, produced not by recombinant LH, but by HCG. And okay, LH and HCG activate the same receptors, but their action is not absolutely the same. So there are some publications showing some clinical difference. Not huge, but there is. So better to use, if there is a possibility, FSH plus LH like Pergoveris, but if impossible, better to use FSH plus menopur than pure FSH in age group around 40.
All right. Again, thank you so much for your answer to this question. Rachel has probably final question, but of course, if you have more, go ahead, type this in. There is still time for your questions, so go ahead. And the question is the double stimulation a cheaper treatment compared to two IVF cycles in normal cycle?
As for me, probably no, because we will use the same number of FSH or even a little bit more if we start in second phase. So from this point of view, it will be the same. Number of ampoules will be the same. Egg retrieval, you will pay twice. Only if the clinic where you are propose some kind of reduction for such protocols for second egg retrieval, but normally it should be the same or even a little bit more. It may be cheaper from the point of view of, for example, foreign patient who come for 2 weeks, stay in the hotel, not 2 weeks but 3 weeks, for example, for double stimulation, but not pay plane to time. From this point of view, probably will be cheaper.
Okay, that makes sense, of course. Again, thank you for your question. I'm waiting. Someone is typing. Let's give it a second. And there is the question here. So, use pure FSH combined with menopur. What is a good quality FSH medication? Are the stimulation medications different qualities, even if the same medication type?
Yeah, very good question. Of course, pharmaceutical companies say that original FSH much better than biosimilar. So, and it is understandable why they are saying like that. From clinical point of view, pure recombinant FSH or FSH biosimilar, I don't see very big difference. If woman has more than 36 years old, I prefer the combination FSH plus menopur or FSH plus LH. Uh, Good quality, probably it will be not very correct from my side to give the commercial names of medication, but most of medication in the market, like Puregon, like Gonalef, like Menopur, like Pergaveris, produced by very serious company with good quality process, and as for me will not be very different from the point of view of final result. Of course, when scientists doing big scientific investigations with thousands of people, probably in some case they will found difference in 1% in some points, but okay. Of course, if you will use something produced, how to say, not by original company, not in appropriate conditions, probably result be less good.
Of
But
course.
most of medications used, as for me, has high quality.
All right, good question. Thank you so much, Karen. Yeah, and I couldn't agree more. Helpful for sure. Thank you for your questions.
Thank you. Thank you. It's a
That's why
pleasure.
we are here, and of course it's good to see so many different questions, of course. So you definitely are making this also I'm sure interesting for all other patients, so thanks a lot. And I believe this was our final question. So everyone, thank you for joining us tonight. It was again a great session with you, Dr. Halyna, as always, so thank you so much for
Thank
joining
you.
us.
Thank you. It was a
Anything
pleasure.
else? Anything else you would like to add?
It was a pleasure. I like these sessions with the questions. You has always very interesting questions, and for me it is really pleasure to answer it. So please don't hesitate to the next session.
Exactly. We will be
Ask your
back.
questions.
Dr. Strelko definitely is going to be with us 11th of October, if I'm not wrong. There is another session. We will talk about poor responders, right? So we will have another
Exactly.
session. So go ahead and you can even sign up already. It's already available on our website. So thank you so much indeed. And before let you go, I just want to add that we will be back on next Thursday, not Tuesday, but next Thursday. On the 6th of October, there is another topic, another doctor. What is the best way to assess implantation failures in IVF? So I hope you will be able to join us. And once again, I would like to remind everyone that European Fertility Society is proudly supported by Phenomatch. And that is it from us tonight. So thank you everyone for joining. I hope to see you very soon. Dr. Strelko, I know that we will see each other quite soon as well. I'm looking forward to it already. Thank you, everyone. See you soon, and enjoy your evening. Thank you. Bye.
Thank you. Thank you. Bye bye.